Good day, students. Today we will start a cycle of lecture of a course of emergency medical care. I am responsible of the course, Roman Ляхович. So, when the situation with the coronavirus stabilizes, I would like to inform you that we have 3 practical classes which will be held on the basis of Regional Center of Urgent Medical Care and Medicine of Catastrophe, which located at 11 Repin Street. So, Service of Urgent Medical Care in Ukraine is a structure that the population of the state of a fast and urgent pre-hospital aid a different situation that can threaten to health or to life of a human. Urgent medical care, and that's one of link of primary help. For aid and treatment of calls, controls and separation responsible dispatching service. Basic mobile functionality structure unit of the station of UMC as a medical team that sends the call in place to provide necessary medical care in reanimation and emergency hospitalization of patients and survivors with the appropriate hits. Such medical care is named urgent. Urgent medical care on the greatest standards must be accessible for everybody and anywhere in any time. It requires the appropriate system of measures on medical care for all people whose life suddenly found oneself under threat, conception of grant of pre-hospital, hospital and inter-hospital urgent medical care. In time as a well-organized help reduced mortality, duration and rate of sudden diseases and traumas, decreases suffering of patients, so one of base positions of the manifesto of European Association of Urgent Medical Sounds. In fact, its actual characteristic feature of our present time is an incessant increase of amount of accidents, catastrophes, elemental and ecological troubles, acute diseases that is combined by different pathological by that states. During the last years, as a result of psychic-emotional loading, increase of rate and rhythm of modern life, the amount of cases of the so-called extreme pathology, to the heart attack of myocardium, violations of rhythm and cardio activity, disorders of the respiratory system increased. There is not a doubt that the endpoint of treatment of patients with such diseases of damages largely depends on the timeliness and adequacy of grant of pre-medical, urgent medical, pre-medical and skilled medical pre-hospital and early hospital help. So, organization of the emergency team in Ukraine. In Ukraine, the emergency medical care refers to primary link of the health care system. It provides emergency medical care for the population. 70% of emergency teams includes doctor, medical assistant, nurse and driver. Medical teams. The rest 30% of teams includes medical assistant, nurse and driver, paramedical teams. This slide presents the structure of medical brigade and the equipment of that, what they are responsible. So, development of systematization of algorithm and protocol of urgent medical care, ANGELG. American Association of Cardiologists, European Association Council, ERC. Last recommendation was published in 2080 and includes next level of resuscitation measures: BLS, ELS, ILS, ITLS, PLS and ICLS. What does it mean by BLS? Basic of life support. Base support of vital functions, namely grant of urgent medical care on the pre-hospital stage by not physicians, by volunteers, policemen, firemen, rescue, etc., or the same physicians that by chance appeared in place of event. ELS, immediate of life support, is urgent support of vital functions that can come true in a polyclinic, permanent establishment, in a private cabinet, and others like that by medical workers to arrival of the specialized rescue medical brigade. ILS, advanced of life support, the extended is skilled medical including reanimation help that is given by physicians and paramedics with bringing of appropriate items, medications, tool on pre-hospital and to the early hospital stage. ATLS, Advance of Trauma Life Support, is a professional grant of the first medical aid at various traumas both on preclinic and on early hospital period, mainly executed by doctors, rare by medical sisters, paramedic. ACLS, Advance of Cardiac Life Support, is a grant of professional urgent medicare at cardiovascular pathology conducted by doctors, medical sister, paramedic. PLS, Pediatric of Advanced Life Support, is a grant of professional urgent medicare for children, comes through by doctors, medical sisters, paraphysicians. How to approach the injured person? Approaching the injured, ask a witness, rescue worker or policeman what has happened, whether the accident scene is safe and how many injured people are there. If the accident scene is, in your opinion, connected with criminal activity, immediately call the police. If there are in need of rescue workers, inform the rescue service. In case of crime or violence, law enforcement agencies have to provide safety for the rescue medical workers. If there is a lack of information, act independently, first of all giving heed to everything which can threaten your safety. The place has to be thoroughly examined. If there is less danger, the container are marked with special signs, some liquid, split, smoke, fog, fire, gas, electric wires, explosive objects, things which can fall from the top, etc. Figure out if you are able to eliminate it without any risk. If not, call rescue workers. In this situation, it is important to keep verbal contact with the injured, find out what bothers him and give him recommendations concerning self-help and mutual aid. If you decide to approach the injured, figure out what has happened, to foresee the mechanism of trauma and to find out the way of providing medical help. Ask one medical worker or a driver to inspect all secluded corners of the accident scene in order to find other possible victims. In case they are found, you have to examine them and provide necessary medical help if it needed. Pay attention to the details of the accident scene. Keep constant control over the accident scene, since additional danger can occur, which will force to save not only the life of an injured, but your own as well. The priority should be your own life, then the life of an injured, and then all people present at the accident scene. Find out if you need any additional help or additional means. So, this is modern algorithm of diagnostic and rendering of emergency medical pre-hospital care is carried out by the so-called principle DIBC. D. Danger. Injuries are very safe for yourself, other, and the patient. Response. Level of consciousness according to the LVPU principle. A. Airway. Open mouth if foreign material presence. Place in the recovery position and clear airway with fingers. B. Check for breathing. Look, listen and feel. Not normal breathing. Immediately start CPR. Normal breathing. Place in recovery position and monitor breathing. CPR. Start CPR 30 chest compressions, 2 breaths. Continue CPR until help arrives or patient recovers. And last, D. Defibrillation. Apply defibrillator if available and follow voice prompts. So, primary examination. Figure out the condition of consciousness according to the algorithm AVPU. What does it mean AVPU? A. Alert, conscious, give adequate answer to the questions, is able to perform conscious action when asked by the medical rescue. For example, are you okay? You are the victim. Yes, I am okay. V. Response to verbal stimuli, to a loud sound near the ears, left side, right side. P. Response to pain, response to pinch in the area of left thoracic muscle at the turn of 180 degrees. And U. Unresponsible. If victim not reaction for pain, his condition is regarded as very, very dangerous. If there is suspicion of simulation of unconsciousness, open patient eyelids using first and second fingers. The conscious patient will strain his eyelids muscle and they will open with tension. Remember, during primary examination, let's make a priori assumption that cerebral trauma occurs at transport accidents, sport accidents, falling from high places, traumas in water and children's traumas. Fix with your hands and neck part of the spine in the position which you found the injured in responsible fast assistant of brigade UMC. If that position does not promote breathing, carefully turn the injured on his back or to the position which is close to a stable medical assistant band, and 2. Start primary examination according to the ABC. So, the Department of Emergency Medical Care for many years, in addition to teaching, is engaged in training in the development of theoretical and practical skills to provide qualified emergency medical care by teams of UMC. The latest medical equipment, medicines, and a set of mannequins are used for this. On this slide, you can see how the teachers of the department show the cadets' basic recitation measures on a mannequin. Also, very important information about golden hour. An algorithm of initial actions of brigade of UMC is in place of happening at the exposure of victims that need urgent medicare. Stage of actions of brigade of UMC and her job performance in parallel instances are based on the so-called principle of platinum half-hour and golden hour. Conditionally, platinum half hours are divided into the parts of 10 minutes. First 10 minutes, arrival to the place of event. Second 10 minutes is an estimation of place of event, including realization of the medical sorting, diagnostics, measures and grants of the first aid in place. And third 10 minutes, transporting suffering in permanent establishment with continuation of realization of anti-shock measures and permanent monitoring of vitally important organs and systems in the coach of UMC. The gold hour includes for entails next 30 minutes, where to the victim in permanent establishment the various, including highly specialized methods of inspection are connected in the urgent order, as them computer tomography, MRT, and other like that, up to beginning to operative intervention. At the same time, there is another conception of gold hour, that interpretation rate of the state of trauma victims with simultaneous realization of the primary medical sorting in obedience to her damages and divided into 3 categories. 1. Irreversible, at that even immediate adequate interventions do not bring to the positive result. More often, a trauma hour what not consonant with life in the medical sorting are black victims. 2. Damages at that consequences of trauma, death or disability depend of timely and quality medical interventions are red victim. Help they get near term with further hospitalization for the grant of the specialized treatment in possible operative intervention during 1 hour from the moment of the got trauma. And 3. Damages at the grant of specialized medicare can be deferred during 1 hour without an obvious risk for life and health or trauma are yellow victim. ABC principle. ABC and its variants are initialism mnemonics for essential steps used by both medical professional and lay person, such as first aiders, when dealing with a patient. In its original form, it stands of airway, breathing and circulation. The protocol was originally developed as a memory aid for rescuers performing cardiopulmonary resuscitation, and the most widely known use of the initialism is in care for the unconscious or unresponsive patient. It is also used as a reminder of the priorities for assessment and treatment of patients in many acute medical and trauma situations, from first aid to hospital medical treatment. airway, breathing and circulation are all vital for life, and each is required in that order for the next to be effective. So, step A. Provide to patients airway support. Responsibility medical system number 1. Evaluate airways if there is need, examine oral cavity. In case of secretion, blood, vomitive mass, outside objects, depending on the mechanism of an injury, it is necessary to open oral cavity. Usually between molar teeth you should put a spreader to prevent accident pressing of fingers. Take out outside objects with medical tongues or tweezers and tampon. Provide cleaning of oral cavity and pharynx. Clean them from secretion. If they are severely injured, the priority is to place them according to the relief of area, head down. Put the patient's head back and raise his chin. In case of suspicion of cerebral trauma, it is prohibited to throw patient's head back. You should raise only his chin. Step B. Make sure if the patient is breathing. Count the frequency of respiration during 10 seconds. Intubation of trachea is considered the most effective way to ensure airway patency and mechanical lung ventilation. Indication for carrying out trachea intubation: apnea, risk of aspiration, danger of presence of respiratory disorder, damage of respiratory tracts, maxillofacial trauma, closed craniocerebral injury, hypoxemia in spite of carrying out oxygen therapy. So, continue step C. In almost all medical and surgical emergencies, consider hypovolemia as a likely cause of shock until proved otherwise. Unless there are obvious signs of a cardiac cause, NJ, chest pain, heart failure, give intravenous fluid to any patient with cool peripherals and high heart rate. In surgical patients, rapidly include bleeding, overt or hidden. Remember that breathing problems such as attention pneumothorax can also compromise a patient's circulatory state. This should have been treated earlier in the breathing assessment. In the following slides, I want to show you the equipment that is modern Ukrainian ambulance according to modern clinical protocols of emergency medicine, which were adopted in Ukraine in 2020 year. So, you can see on this slide a chart for mobilization, transportation, welcome barrel. Next slide, please. You can see hard shift, soft stretcher, type of frame stretchers, electrosuction fan, right side upper pulse oximeter located on the finger on patient, cardio complex, medical bag for transfers of medical property and medicines. This is immobilization, neck collar, pectoral immobilization, Vanscott and vacuum splint, other splints, Kramer splint, elastic splint, type some splint, and elastic tip, yes, suction units, patency or airway support, respiratory mask. You can see alternative method to intubation, laryngeal mask and laryngeal tube. Yes, different calibers, laryngeal tubes. Also very interesting combi tube to provide patency, or respiratory mask and ambu bag with connected by oxygen. Yes. A set for cricoterotomy. A cricoterotomy is often used as an array of last resort given the numerous other array options available, including standard tracheal intubation and repeat sequence induction, which are the common means of establishing an array in an emergency scenario. Cricoterotomies account for approximately 1% of all emergency department intubations and in used mostly in persons who have experienced a traumatic injury. Some general indications for this procedure include First, inability to intubate. Second, inability to ventilate. Third, inability to maintain saturation more than 90%. And last, severe traumatic injury that prevents oral or nasotracheal intubation. So, general intubation for indications for intubation. Remember, absence of independent breathing or less than 10 during 60 seconds or more 40 breaths per 1 minute. Yes, saturation less than 90, early period of burns of the respiratory tract. So, this slide presents a portable of respiratory equipment, left side support artificial ventilation of lungs, and right side oxygen therapy. This is training mannequin for developing skills of patency or reverse support. Yes. This slide presents the algorithm for diagnostic and performing primary and secondary examination of a victim in serious condition, from primary examination to secondary examination with category patient load and go. So, category load and go after primary examination. Under the following circumstances, a patient must always be alert and go. Altered level of consciousness. Next, any compromise to the airway, any compromise to the breathing, any compromise to the circulation, deadly bleeding, change of skin color, temperature or condition, spinal mobilization has been taken, pelvic fracture, femur fracture, and internal bleeding. If head of brigade determines the patient to be alert and go, the following protocol must be followed. Note the patient history can usually be taken at the same time as the patient is being packaged. Patient history, package patient, begin transport, check vital, recheck vital every 5 minutes or if a change in the patient condition occurs, performs a assessment survey and begin treatment. Stay and stabilize. If none of the above conditions exist, head of brigade may choose to stay and stabilize the patient before transport. If head of brigade determines the patient to be a stay and stabilize, the following protocol must be followed. First, patient history. Second, check vital, recheck vital every 5 minutes if a change in the patient condition occurs. Third, perform a assessment survey. Fourth, begin treatment. Fifth, package patients. And sixth, begin transport. So, on the next part of my lecture, we will talk about respiratory and circulatory arrest, model algorithm, cardiopulmonary and cerebral resuscitation. So, one of the most important tasks of becoming a physician is to acquire the skill of cardiopulmonary cerebral resuscitation, which allows to renew the vital functions of life. Okay, on this short video you can see how close the death can be to anybody. Intensive therapy and resuscitology. Concept of intensive therapy is a complex of temporary method of artificial maintenance of vital life functions in the compensated stage, which is directed to provision of life support. Resuscitology. Study about revival of the organism, prophylaxis and treatment of terminal stage according to Nigorsky. Non-traumatic, unexpected fatal event occurring within 1 hour of the onset of symptoms in an apparently healthy subject. If death is not witnessed, the definition applies when the victim was in good health 24 hours before the event. The term is used when a congenital or acquired, potentially fatal cardiac condition was known to be present during life. Autopsy or autopsy has identified a cardiac or vascular anatomy as the probable cause of the event, or no obvious extracardiac causes have been identified by a post-mortem examination, and therefore an arrhythmic event is a like case of death. So, terminal states is divided into several stages: pre-agony, terminal pause, agony, and clinical death. Pre-agony: falling of arterial pressure, loss of consciousness, decrease of metabolism. Terminal pause: terminal pause, arterial pressure and breathing are reduced, functional of the central nervous centers becomes chaotic. Third, agony: further fall of the blood pressure, cessation of breathing, and a sudden return to consciousness for a few minutes. After that starts steep reduction of all vital functions in the last spark of life. And fourth, clinical death. What does it mean, clinical death? Time of cessation of blood circulation and breathing, the two criteria necessary to sustain the lives of human beings and of many other organisms. It occurs when the heart stops beating in a regular rhythm, a condition called cardiac arrest. Main sign of clinical death and additional sign of clinical death. Main sign: absence of pulsation of mediastinal arteries, usually carotis or femoralis, jugular. Second, pupils are fixed and dilated, not reactive to light. And third, abscess on independent breathing, or one breath per 10 seconds. Additional signs: change in skin color, sometimes possible gray, bitter or cyanotic. Second, absence of consciousness. And third, absence of reflex and loss of muscle tone. So, CPR involves chest compression for adults between 5–6 cm depth and at a rate of at least 100 to 120 per minute. The rescuer may also provide artificial ventilation by either exhaling air into the subject's mouth or nose, mouth-to-nose technique of resuscitation, or using a device that pushes air into the subject's lungs, mechanical ventilation. Current accommodation places emphasis on early and high-quality chest compressions over artificial ventilation. A simplified CPR method involving chest compressions is only accommodated for outright rescuers. In children, however, only doing compressions may result in worse outcomes, because in children the problem normally arises from a respiratory rather than cardiac problem. Remember, chest compression to breathing ratio is set at 30:2 in adults. On this slide you can see quick evaluation: type of blood circulation blockade with defibrillator plates, center picture, and right side adhesive electrodes. So, on this slide you can see modern protocol of CPR according to last recommendation of European Resuscitation Council. You see, left side, right side, different situation, different way. First of all, must remember, we have rhythm prior to defibrillation and rhythm not to defibrillation. Rhythm prior to defibrillation, ventricular fibrillation and ventricular tachycardia; not to defibrillation, pulses electric activity and asystolia. So, up ventricular fibrillation and down ventricular tachycardia. Ventricular fibrillation: if we feel the ventricular myocardium depolarizes randomly, the ECG shows rapid, bizarre, irregular values of widely varying frequency and amplitude. VFE is sometimes classified as a cause of fine depending on the amplitude, height of the complex. If there is doubt about whether a rhythm is asystolia or pulse electric activity, do not attempt defibrillation. Instead, continue chest compression and ventilation. Very fine VFE that is difficult to distinguish from asystolia will not be shocked successfully into a perfusion rhythm. Continuing good quality CPR may improve the amplitude and frequency of the Wi-Fi and improve the chance of successful defibrillation and a perfusing rhythm. If the rhythm is clearly Wi-Fi, attempt defibrillation. Ventricular tachycardia, VT. Ventricular tachycardia, particularly at higher rates or when the left ventricle is compromised, may cause profound loss of cardiac output. Pulse ventricular tachycardia is managed in the same way as Wi-Fi. The ECG shows a broad complex tachycardia. In monomorphic VT, the rhythm is regular or almost regular at a rate of 100-300 per minute. Evaluate rhythm. If you receive rhythm prior to defibrillation, immediately do ECG. Post-ECG control, receive fibrillation, immediately do defibrillation. Biphasic 150-200 joule, monophasic 360 joule. After that, immediately defibrillation, post-ECG control. Only post-start defibrillation used medical drugs. Remember, after performing defibrillation, continue CPR for the next 2 minutes. Stop CPR only when patient has signs of circulation. Defibrillation priority. Adrenaline 1 mg with normal saline in syringe, the same 1 cc post-start defibrillation. Amiodarone 5% 300 mg, the same 6 cc with glucose in syringe, also post-start defibrillation.
In a real clinical setting, an AED system is normally used. At the Cape, we use a monophasic defibrillator. You must place the paddles on the mannequin's chest plates when using the defibrillator. Many institutions are switching to the biphasic defibrillators. Our mannequin can only be used with a monophasic defibrillator, which can reach 360 joules as compared to a biphasic system, which can only reach 200 joules. The defibrillator is fully functional. Depending on your scenario, the defibrillator can be used as an operative defibrillator or the use may be simulated. When using the defibrillator, the left paddle is placed on the sternum and the right on the apex. Effective use of the monophasic defibrillator requires 2 individuals. Release the paddles from the defibrillator by using the release mechanism located at the left and right side of the defibrillator. Turn the main dial clockwise and select Monitor. Press the lead button until the word paddles appear on the screen. Place the paddle on the sternum and the other on the apex. View the waveforms on the defibrillator monitor. If your patient needs to be shocked, turn the dial clockwise and select defib. The individual assisting must be informed of the desired energy level. 360 joules, please. Push the energy button until the desired energy level is selected. Then push the charge button. A low-pitched noise will occur, alerting you that it is charging to the desired energy. A high-pitched noise will then sound once it has reached the desired energy level. Before delivering the shock, you must inform your care team to clear the area surrounding the gurney or bed. A commonly used phrase is, "I'm clear, you're clear, we're all clear." It is important to maintain eye contact with the care team when announcing this. Once the surrounding area is clear, use your left thumb and right thumb to push the corresponding orange buttons located at the top of the paddles. A shock may now be administered. After administering the shock, leave the paddles on the mannequin's sternum and apex plates. Viewing the waveforms on the monitor will alert you to the status of your patient. You may then act accordingly regarding use of the defibrillator.
So, rhythm not before defibrillation. Up. on up asystole, down pulses electric activity. Asystole. Usually there is neither atrial nor ventricular activity, and the ECG is a more or less strange line. Deflections, which can be confused with fine Wi-Fi, can be caused by baseline drift, electrical interference, respiratory movements, or cardiopulmonary resuscitation. A completely straight line usually means that a monitoring lead has disconnected. Whenever asystole is suspected, check that the gain of the monitor is set correctly and that the leads are connected correctly. If the monitor has the activity, view another lead configuration. Atrial activity, P waves, may continue for a short time after the onset of ventricular asystole. There will be P waves on the ECG, but not events of ventricular depolarization. The patient may be suitable for cardiac packing. Pulses electrical activity, PA. The term pulse electric activity, sometimes referred to as electromechanical dissociation, EMD, means normal or near normal electrical activity without effective cardiac output and is treated as cardiac arrest. The diagnosis is made from clinically absent a cardiac output but a rhythm that would normally be accompanied by a good cardiac output. So, remember, action if you receive asystole or PA, check for electrode connection, adrenaline every 1 mg every 3 per minute during CPR. So, potentially treatable conditions 5H and 5T. 5H, hypovolemia, hypoxia, cardioganglion acidosis, hyperkalemia, and hyperthermia. 5T, toxins, tamponade, tangent pneumothorax, thrombosis, heart acute massive and thrombosis lungs massive. On this slide you can see ways of drug administration during cardiopulmonary resuscitation. Intravenous, intraosseous, intratracheal, intra-arterial. So, intravenous access for emergency care, for example, in the United States, easy, 68%, yes, hard 17%, and impossible about 15%. According to other data, providing peripheral intravenous access in the pre-hospital stage can take 10 minutes or more. Peripheral intravenous access cannot be established at all in 6–10% of cases. At the last time, grade popularly intra-bone access as alternative for intravenous access. In this slide you can see indication to use this method. Pediatrics, children in critical condition without attempts to establish intravenous access, and mass cases, catastrophe, and other problems. So this is modern automatic devices. From left side, sternal semi-automatic device, new bone injector. In the middle, electric drill with a needle from USA. And alternative, this method, bone injector gun big from Israel. So, and drug which use at the CPR, oxygen, adrenaline, amiodarone, lidocaine, magnesium sulfate, calcium, natrium, bicarbonate, dopamine, and hormones. So, students, remember during CPR, rule out potentially treatable conditions, check placement of electrodes, check IV or intraosseous availability, airway patency and oxygen. Remember about after maintenance or airway patency, conduct continuous chest compressions, inject adrenaline every 3–5 minutes, choose amiodarone magnesium. Summary: algorithm RLS standardized array of treatment for circulatory arrest in adults, all to increase effectiveness on treatment. Thank you for attention.